in just a moment. Welcome, everyone. I am Michael Morella, Managing Editor at U.S. News and World Report. Today, we've assembled a panel of experts to discuss the persistent, troubling challenge of violence against healthcare workers. Our speakers will focus on strategies and approaches that are really working, as well as how institutions with widely different resources can adapt them to fit their unique needs. We want to thank Flock Safety for their support of today's event. Now, before we turn to our discussion, just a couple of housekeeping notes. We are recording video of today's session, and we will be sharing a link with all registrants in the coming days. Video will also be archived on usnews.com. Now, on our site there, you can also find more details about today's speakers, as well as a range of upcoming virtual events and videos from past sessions. And finally, we do welcome your questions, those of you who are with us live. As you have them, please type them into the Q&A feature in Zoom on your screen, and our moderator may give voice to those later on in the hour. Now, I'm very pleased to welcome our distinguished panelists. With us today are Eric Clay, Vice President of Security Services for Memorial Hermann Health System and President of the International Association for Healthcare Security and Safety; James Giuliano, Senior Vice President of Operations and Chief Clinical Officer at the Ohio Hospital Association; Dr. Jennifer Mensick Kennedy, President of the American Nurses Association; and Garrett Langley, Chief Executive Officer of Flock Safety. Welcome to you all, and thanks for being with us. Now over to my colleague, U.S. News Managing Editor Liz Whitehead, to lead the discussion. Liz?
Thanks very much, Michael. Let's dive into this very important discussion. Can we start by having each of you briefly describe your role at your institutions and whom you serve? Eric, do you want to kick us off?
Certainly. I'm the Vice President of Security for Memorial Hermann Health System, which is made up of about 17 hospitals and hundreds of care sites throughout the Houston metro area. I also serve as the chairman of the Workplace Violence Committee here. Additionally, I'm the president of the International Association for Healthcare Security and Safety, which represents healthcare security professionals from around the globe, and we certify tens of thousands of healthcare security individuals each year.
Thank you. Jennifer?
Hi, I'm Jennifer Mensick Kennedy. I am president of the American Nurses Association, and the American Nurses Association represents the interests of the nation's over 5 million nurses.
Thank you. Garrett?
Yeah, thank you. My name is Garrett Langley. I actually had the pleasure of starting Flock 7 years ago. My neighborhood was the victim of an organized crime, and I'm a proud Georgia Tech engineer, and we build things. And so we built Flock off of that crime, and now have the pleasure of servicing about 5,000 cities across America, helping keep them a little bit safer every single day.
Thank you. Jim?
Hi, good afternoon, and thank you for having me. I'm James Giuliano. I serve as Senior Vice President of Operations and also the Chief Clinical Officer at the Ohio Hospital Association. We serve 250 hospitals and 15 health systems within our state. My responsibilities include oversight of the clinical services that we provide, as well as the member services that we provide.
Thank you. Eric, in order to really attack a problem, you've got to understand the scope of it. Can you give us a sense of what the statistics are telling us about the trends of incidents involving violence at hospitals over the last few years?
Certainly. Let's say over the last few years, there's been a number of anecdotal and data-based reports that have come out that have really discussed the issue of workplace violence in a healthcare setting. We have seen a tremendous increase, I think, in these incidents. I think OSHA advises about 73% of all workplace violence incidents occur in a healthcare setting. There was a Press Ganey report that came out recently that talks about 57 nurses being assaulted each and every day. And at IHSS, it's become so accepted that we can now predict exactly how many incidents within reason that you're going to experience. You have, for every 100 beds you have, we anticipate 4.7 incidents of workplace violence occurring in your facility. And we know, as disturbing as those numbers are, that they're, for a variety of reasons, it's greatly underreported. So as high as those numbers are, just know that it's a bigger problem than what we even realize.
Yes, and later in the discussion, we want to get into why they're underreported. Jennifer, can you give us 30,000 feet perspective on the millions of nurses that you represent from their perspective and yours? Is the problem getting worse or better? And what is the impact of these incidents on patient care, staff morale, and community relations?
Absolutely. So we know 1 out of every 4 nurses at least has experienced workplace violence, and this is higher than police officers and prison guards. So this is a bad situation. And we know 39% of nurses report that, just in general, that their work environment is negatively impacting them. So when we have a bad work environment in a healthcare setting, where it's super important to make sure we have good communication, we have safe processes, this can lead to negative outcomes for patients. Increased medication errors, increased patient falls, injuries to patients when the work environment is such that nurses, providers, social workers, physicians, everyone cannot practice safely. So this has a very negative impact to anyone coming into the hospital when these incidences are on the rise.
And when you talk to your nurses, does it impact their decisions to stay in the industry or to stay at the patient's bedside?
Absolutely. When individuals look at the options they have, and when they don't feel that the organization is providing them a safe work environment, after one incident, for instance, they're going to leave. My husband is an example, who was an ICU nurse, and several years ago had an incident where a patient threw him up against the monitors in the ICU, and he injured his back so much that he could not even continue practicing at the bedside. So when we have nurses who are injured to that extent, that's just another level of, do I place my safety or my own physical safety in, continuing to do this if I'm not safe? So I think we have nurses who physically are getting injured and cannot continue to practice, and those who see this happening and are, like, my family and myself are worth more, and so are taking themselves out of these situations because they're not safe.
Garrett, how would you work across different sectors? How would you characterize the specialist challenges faced by hospitals in addressing the issue of hospital violence? Are there analogies that you can make?
Well, I think Jennifer made a really astute point, which is, clearly from whether it's a nurse or anyone working in the hospital system, they want to be safe. But I also think no one wants to be also, they don't want to work in a prison. And that's, I think, the crux of the problem, which is I'm sure Eric's a smart guy. I'm sure he could lock down his hospitals, perfect safety. But we also need to be a place that's welcoming, right? I mean, hospitals are places of joy, places of fear. And it probably looks closer to how we think about the K-12 customers we have, where it's like, look, I've got 2 young kids, and I want them to be safe, but I also want them to feel like they're going to school. And schools need to be open. Schools need to be welcoming. And I think our hospital systems have the same problem. And so you wind up having to have this debate of how do we balance overt security measures with covert security measures? And how do we balance being proactive with being reactive? And I think that is the number one challenge that a hospital faces, because I know for a fact Eric probably has a security plan that he would love to implement, but he also knows he has a North Star mission, which is to make people healthy. And the safety is a part of that, but that's actually not the number one mission. That's a little bit different than, we do support prisons as an example, as a customer base, and that's a little bit of an easier problem than I think our hospitals and our K-12 schools have it.
Yes, and that's what I'd love you all to be able to address as we move into the discussion of how you balance those conflicting missions. Jim, from your perspective in Ohio and seeing hospitals have vastly different resources, can you talk a little bit just about the range of institutions that have to think about safety and how cognizant everyone has to be that some hospitals can do X, but others can't, and tailoring solutions for their individual needs?
Yes, Liz, in Ohio, we are not unlike other states in that we have a very diverse group of hospitals that are located in rural parts of the state. We have others in more urban parts of the state or suburban parts of the state. And so it's really important to tailor solutions to the environment. One of the things that we think of immediately is the culture of the organization. Is there an ability to share information freely and to collaborate freely among departments between safety and security and the clinical providers as well? The way an organization interacts defines that. And you know it when you walk into an organization. The community that we serve needs to be a consideration as well. You know, Garrett, you just mentioned the fact that we want a safe environment, but we also have to define to the community and communicate to the community why we're doing what we're doing. A patient said to me recently, I haven't been to the emergency department in my local community for over 2 years, but I had to go last week. And my goodness, things changed greatly. It looks like a completely different. Why is that? Is it safe? You know, and then there was the explanation that these modifications to the campus have been made to ensure safety. And so there is a public image that needs to be communicated as well. I think also the resources that are available, you touched on this, Liz. You know, am I in an environment where I'm wearing 2 and 3 hats because I don't have the level of resources in my particular area? Or am I in an environment where there are layers of support and everyone bears a different title? And so we see that happening in some of our hospitals as well. And I also think the partnerships that are established within a community with law enforcement, with mental health resources in the community is so very crucial. So all of those things to me are part of the considerations to tailor a plan to the diversity that our membership is.
Thank you. So you mentioned some critical elements of a security plan. I'd like to ask Eric to talk about what would be a comprehensive security plan, and then we can break down and talk individually about those parts, and then who can do it and who may not and may have to adapt. Eric, can you talk to me about sort of the key elements of a security plan, and then also we're going to pick up later on what Jim said about who needs to be in the discussion. Go ahead.
Certainly. I think as Jim alluded to, there's not a one size fits all approach to security. Different institutions, organizations are going to have different resources. Even within that system, different hospitals may have different resources assigned to those hospitals. But I think everything needs to start with a security assessment. You look at your facility, you look at the community around your facility, and you determine what are my risks involved in operating here. You identify your vulnerabilities at that point. From there, you begin developing your mitigation strategy, crafting your security plan, which is going to include technologies that we've kind of discussed a little bit here today, strategies such as security officer staffing ratios. How many officers do I need to patrol my facility and prevent things from happening rather than just responding to things after they've occurred? Your CCTV cameras, your de-escalation teams, your developing relationships with your local law enforcement agencies, deployment of different technologies like fixed and wearable duress alarms, LPR cameras, concealed weapons detection, access control. I mean, there's a great many things that go into that plan.
So, Jennifer, when you start to have the discussions at an institution about each of these elements or putting together the whole mosaic, who should be in those discussions?
That's a great question. And oftentimes, the direct care providers, the nurses, are not involved in those conversations. And they need to be in those conversations. As noted, this is going to look different depending on your facility, but even within the facility. And what occurs in your OB birthing center may be different than the pediatric department, and it's different than the emergency room. And so those staff are going to have different needs or desires. They're going to have different experiences. And so as you're building that plan, if you're going to be really thorough about protecting and improving safety, you're going to want to get the perspectives of those clinicians and those nurses in each of those areas as well. So having that voice of experience that says, here's what happens when this occurs, or here's what my experience is really going to be invaluable.
And do you feel that the nurses are sort of horizontal and they go through every aspect of the organization? What about vertically? Who needs to be? Are we going high enough? Are we going, to the most junior staffers? What would you say?
Absolutely. I think, what an important component of all of this is not only do we need to have safety teams and looking at this at a unit level, but this should escalate up into reports. The department should see this, the hospital level, the CEO should be seeing this, but also the board of directors needs to be seeing this type of information to know how safe is their organization, what's going on. And so they need to be held accountable to the patient's safety as well. So I think we really need to make sure that everyone's involved at every level of the organization. And oftentimes I think hospital boards, healthcare boards, may be focusing on a few components, but they really need to make sure this is one of those pieces that they're informed about and that they actually participate in ensuring that their organization for their community is safe.
Jim, do you have thoughts to add on who should be in the conversation early on?
Liz, I completely agree with Dr. Kennedy. I mean, this needs to be very inclusive. I think that would be the one word I would put out there, inclusive. And by that, I mean, you've heard the expression, it takes a village. I think that when it comes to constructing a viable solution that we have in hospitals, and I've seen this happen in Ohio hospitals over and over again, we have expanded and broadened that village. And that's a good thing because we have included frontline staff who have lived experience with violence at the table. And these are the same individuals who are highly concerned about a safe patient experience, providing safe patient care. Patient safety has always been top of mind for clinicians, and I'm very proud of that. But now we have to broaden that safety definition. And so that includes everyone being at the table, leaders, frontline staff, safety and security professionals, who are all together walking the footprint, identifying vulnerabilities, as Eric mentioned earlier. And it's very important because staff need to buy in and support this plan. And the only way to do that is to have them there from the beginning as well. So that's what I would add.
Garrett, you've worked with a lot of institutions to provide, support security services. Do you have a perspective too about what organizations have been able to implement most effectively in terms of who's been in these conversations?
Yeah, I think one, to Dr. Kennedy's point, you definitely need to have a broad perspective. I think what's just as important, though, that we haven't mentioned is how broadly you communicate that plan. Because a lot of what people like Eric are doing is intended to be covert, right? You don't want the patients to see it. And the risk you run with a lack of a communication plan is that your nurses and your doctors, hospital workers have no idea. And I think some of the most impactful implementations we've seen, whether of our technology or their technologies, is where it is the CEO, it is the leader of the hospital saying, safety matters to me. And I want you to come to work. I want you to feel safe. Here are the things we're going to do. You're going to notice some of them. And some of them, here's what we're going to do. Here is the plan. And you will never see it. And you will never know it's working, but know it's working for you. And I think so much of this is about providing peace of mind for our employees so that they continue to come to work, because I do think the attrition challenges and the staffing challenges facing our hospital system are not going to go away easily. I think we have quite a bit of work to do.
Eric, do you want to add onto Garrett's comments?
Yeah, I completely agree. I think that security practitioners quite often are sometimes we're the worst people to advertise what we're doing. We think everything should be a secret. And part of what we do, we play two different key roles, I think, in that we provide that protection, but we also mitigate anxiety. And by communicating what we're doing, we can mitigate some of that anxiety. And to me, that allows caregivers to focus on providing the high quality care that they want to give to their patients. It allows their patients to focus on healing. So to me, really communicating, we try to do town halls at institutions where we come in and we say, here's the security measures that we're implementing. Here's the successes we're seeing. Here's the challenges. We need to fix these. And as Dr. Kennedy said, I think that, having a lot of different stakeholders, because again, what looks good to me as a security practitioner, I may say, this is the perfect solution for what you've got. But when I talk to the nursing staff who make up the vast majority of our organizations, they're going to tell me that's not going to work, and here's why it's not going to work. So bringing them in early can allow you to be more successful, to not waste money and time on resources that you think is the proper solution for that, but really isn't going to have the intended effect.
Garrett, I'd like to swing back to you for this next section, which is to talk about the technology piece for security. Can you give us a sort of overview of the different options and how they might work together? Surveillance, wearables, license plate readers. Go ahead.
Yeah, I think there's to Eric's earlier point, there's like 1,000 things you could be doing. I think what we try to think about is, well, let's actually just focus on the problems you have and then get to the solutions. And I think often with technology in general, we jump to, well, this is a very shiny ball. Let's go implement it. And you're like, yeah, but what's the actual problem? And how will we measure that success? And so I would probably bucket the technologies in three big groups. You mentioned wearables. That's a great example. There are things we can do to put on our employees to help create a safer workplace, whether that is non-lethal weapons, whether that is emergency buttons, whether it is cameras. Like, there are a handful of things we can do on the employee. And then there's a handful of things that we can do in and on our buildings. So Eric mentioned access control. Yes, an integrated access control system that allows you to shut down the doors or lock the doors quickly is an obvious thing. Or you think about, excuse me, I was at the hospital, sadly, 2 weeks ago with my son, and there were metal detectors. Novel. Sorry, 1 second. And then the third is moving the security to the perimeter. And that's kind of where we step in, which is, how do you think about the defense going farther out and less just the building?
So Jennifer, he mentioned, you mentioned, first of all, your husband and that terrible incident he went through. Just how important is something like wearables and emergency buttons? I mean, alert buttons. I mean, if you've got somebody is dangerous and they're blocking your access to a phone or to exit the room, can you give us your perspective on what's valuable?
No, absolutely. And I think this goes to that whole range of, security possibilities, because you want to have a healing environment, but as soon as you see the metal detectors, that kind of squelches that perception. But at the same time, it gives you a safety perspective that the metal detector is there to help reduce, because you'd be, I'm still surprised going through the airport and the number of guns that are caught through security every single year. I just don't understand. But having, if we're taught to, not put our back towards the wall, make sure you have a clear exit, those types of things, where if a nurse couldn't, reach for the code button or reach for a button on the wall or yell for help, is really important to be able to access help. And I think too, there's, those ancillary sites outside of the hospital. Oftentimes we think of hospitals, but about 43% of nurses don't actually work in hospitals. So we have nurses in ambulatory and clinics and home care. And I think about the several nurses this year who were killed in patient homes, who were stabbed outside of their clinics. And so having the technology, in the perimeters, but also from a safety perspective, is going to help people stay safe, because we want to be able to provide care to wherever people are. And so this is going to look different depending on the setting. And all of these technologies are going to be able to, in some instances, that wearable is going to keep people safer, while also giving that perception of a healing environment, because it's not as visible as that metal detector. So these are things that people would really welcome. It's an unfortunate that we have to have this, but if this is what's going to keep us safe and keep us practicing and keep the environment good, then these are really needed technologies.
Jim, do you have some thoughts just on the technology piece and how different institutions, a small rural hospital versus a large urban institution, how they prioritize what they invest in? Again, just sticking to the technology piece right now.
Yes, I think what is so critical to remember, regardless of composition of bed size in a hospital or the community, is the need. And it begins there. And that is the value of having the frontline staff being included in the plan, because those with lived experiences can identify those improvements that need to happen, such as the positioning of furniture in a room, the positioning of a computer on wheels, the ability to face outward, entry points, access points. These are individuals that know the footprint very well. They practice there every day. And so we listen to them. And then that informs what our plan should be. And yes, of course, we look at resource allocation, but we prioritize based upon safety issues. And I think the moment that we bring people to the table and listen and act on it, then we're making the right decisions.
Garrett, did you have something you wanted to add about that prioritizing?
Yeah. I also think this is connected to Jennifer's point that there's probably this two buckets, which is like, there's an environment where if the patient themselves is violent, we're in a really tricky situation here, because it is our obligation to service everyone in the community. And I think the other way to look at the problem, now that I've caught my voice back, is separating out how do we deliver that kind of service while also trying to prevent kind of known or unknown bad actors from entering the facility. And I think that's like another interesting thing to think about as we kind of try to put all these different pieces of technology into buckets that make it easier to think about. That might be another framing, is you've got, how do you help respond when a patient is violent, where we have to admit this person, we have to provide service to them. And then how do we prevent bad actors, whether that is an active shooter or a family member of a victim or a family member of a patient? How do we prevent those bad individuals from getting on property or getting in the facility? And I think those are two separate problems, but are equally important.
Actually, I'd like to let us talk a little bit more about the repeat violent patients, and then I would like to go into de-escalation teams. But this is the most alarming extreme example. And can you all explain to the audience what you have to deal with in terms of your requirements by law with these patients? Somebody's come and they've been violent. Jennifer, I want to actually come to you. And there's a story you told me when we were talking earlier about your sister who's a police chief, and I'd be appreciative if you could share it.
Absolutely, and I think she was a police officer and a police chief in a smaller rural community. There's a couple of hospitals, and these repeat offenders would bounce back and forth between the hospitals, and she'd come and investigate the abuse, but we couldn't get the nurses. She couldn't get the nurses or the staff to press charges. And she would ask and ask, like, I need to be able to take care of this and stop this from happening. And so it's been really difficult. It was very difficult to, really get some of these people who were bad actors, who were, abusing and being violent to the hospital staff and to the nurses. But people were afraid that they weren't going to be supported. And this is a really complicated issue because they felt that the administration wasn't going to support them if they pressed charges. But at the same time, they felt this, that piece of being a nurse is I need to take care of everybody. But at the same time, it was, where does that really end? If someone's going to continue to abuse you or abuse you, where does your dedication to helping that person heal need to lie? So it becomes a really complicated situation if staff don't feel that they can, safely report some of these events, let alone press charges to stop some of these larger repeat offenders.
I'd like to ask Eric and Jim, and then come back to Garrett to talk more. Eric, can you give your thoughts on this whole problem of nurses feeling or any staffers feeling they can't report for a variety of reasons? And how do you try to deal with that?
Yeah, I think there's a variety of reasons typically why nurses don't want to report workplace violence. I think that most of them are caring individuals who got into the role for the right reasons, and they're typically very tolerant of things. They sometimes, I think, see things as part of a clinical issue rather than just a violence issue. But I think that there are behavioral health patients. I think there are other issues, though, around people who are voluntarily intoxicated or under the use of controlled substances who act out or just have different issues on why they want to do it. But I think that overall, there's just a culture there that is accepting of workplace violence at this point. But I think we're making progress in changing that. I think by educating nurses earlier on in nursing school and talk about workplace violence, I think that's a tremendous opportunity that we need to seize. It's troubling to me to see new nurses or graduate nurses who come out and they are unaware of the problem, and they've now got $50,000 worth of debt for where they went to school, and they're leaving the industry and they're saying, I can't deal with the workplace violence. So I think education is a key component of that. I think as Dr. Kennedy alluded to, there's sometimes a fear of being blamed for the violence. What did you do to upset the patient? I think there's sometimes a lack of awareness in the reporting system. I think we have to make the reporting very easy for people to do, not complex. It has to be easy to find. It has to be easy to file your report. To me, that's critical for us in the security industry, in that we want to do a better job of protecting people. But if we don't know this full scope of the problem, it's very difficult for us to craft a mitigation plan that's going to be effective. So to me, getting and encouraging that sharing of information so that we can staff appropriately, We can, that you kind of alluded to the flagging and the EMR. I think that's critically important to do. I think that, we need to do everything we can to better protect our caregivers, and giving them that information early on is important, because it allows them to make different decisions, to position themselves differently in the room, to maybe bring in another person when they enter the room, so that there's two of them there that can kind of watch and help each other. I think little things like I've seen hospitals that put color-coded bands on the wrists of patients that are prone to violence. I think little decals on the door, that's another great thing, because you get people who don't have access to the EMR who may be servicing that room. It could be EBS, it could be food service. Seeing a decal on the door that tells them this patient's prone to violence, or potentially there are some triggers, they can go to the charge nurse or someone else and say, can you assist me with this? Or can you tell me what the issues are, so I don't do something that potentially could trigger this patient and cause problems. And then I think there's also a belief that, reporting is not going to accomplish anything. Quite often there's no prosecution in these typical events. There's other issues around that where they feel like there's really no reason for me to report this. So I think if we can address some of those concerns, we can have a tremendous impact on incidents of workplace violence.
Yeah, and we got an audience question on this point, that a lot of healthcare workers feel that there are no consequences for the people who engage in this kind of conduct. One said that I've experienced cases where local prosecutors have refused to prosecute offenders for workplace violence, which can really make staff feel helpless. And later on, I want to actually talk about the law enforcement piece in detail, how to build that relationship. But Jim, I want to get you in on this about do you have members who've been able to figure out an approach to these repeat violent offenders? And again, it's HIPAA, and you've got other regulations which require you to see patients who need attention. But can you offer your thoughts on this whole idea, and then the concern that some staffers feel is that they're not encouraged to report?
Sure, absolutely. First and foremost, we've been for ages just laser focused on patient safety, but I think the message is loud and clear that violence is not an expectation of the profession, whatever profession it is within healthcare. It is not an expected. This is not something that we need to just accept and say, oh, this was an expectation. It's Monday, I'm working 3 to 11 shift, and so I expect that I'm going to be verbally assaulted or physically assaulted. That is not okay. And so that messaging that must begin very early on, as Eric mentioned, is very critical. I think another issue that you touched on, Liz, was the issue of risk. And we talk about what is predictable, but we don't know what every patient encounter will lead to. But there are areas of higher risk and lower risk within the confines of a hospital, for example, that we can plan for ahead of time and say, training needs to be heightened in this area, or training should be tailored in this area for that increased level of risk that may occur. For example, in a care area where perhaps emotions are very high, where illness is very critical, we know that often generates issues of very, very high emotion, as opposed to someone who's working in an office setting that doesn't have patient and family interaction. There may be lesser risk. I'm not saying the risk is gone, but there may be lesser risk. So we have to tailor that as well. In terms of your question regarding staff reporting, I will tell you that in Ohio, we've convened a number of forums, and what we hear resoundingly from our hospital leaders as well as our hospital staff members is that the incidence of hospital violence is absolutely encouraged to be reported. But as was mentioned earlier, staff need to be willing to do that. There are processes in place, there are systems in place, but if a staff member is not willing to do that and follow through, that's another story. So what can we do about that? I think that's the more important issue. Well, we need to encourage it in a number of ways. I spoke to 2 of our security leaders in our member hospitals just yesterday, and both of them independently spoke to me about how they walk through the path of reporting an incident with a staff member, because it can be very upsetting to them. It can take extra time. It could be something that they just avoid, and they will spend the time with them to say, I'll walk you through this. I'll walk you through the process. Some other realities that we have in front of us is that there's variation throughout the country. In some states, assault of a healthcare worker is a misdemeanor. In other states, it's considered a felony. In other states, it depends on the number of times it occurs. And so whether that gets heard, whether that case goes through, whether, it does vary. And we do have variation. So that is a reality as well that we must deal with. But I think hospitals being able to make it as seamless and as easy as possible to do what Eric said, get that data so we could trend it out and figure out where our weak points are, helps us then to design our plans to be more effective.
Here, everybody's mentioned some really important points in dealing with these incidents, but one of them is prevention. Another is kind of having a warning period so you can get the de-escalation teams in place. And then I want to move to who should be on one. Can you talk about how, again, how this technology piece can fit in with the human piece to help a hospital better respond and prevent incidents? So if you've got somebody known, what can you pick up? Is it the license plate readers? Can you talk about that?
Yeah, I mean, Eric made a great point that I think impacts all of our communities and hospitals included, which is like absence of a report. There's no data, there's no next step. And so I agree, I've got to continue to report, even if it feels like it's going nowhere, because I don't think it's going nowhere. I think it's being heard. It's just a complicated problem. But, we have a healthcare provider, hospital system we work with, and their workflow is really compelling. And when any of these cases happen, a vehicle gets added to their hot list. This hospital system has over 500 known violent offenders in their system now. When those individuals come back on campus, the de-escalation team is notified immediately. So this isn't like, oh, they've shown up, they're checked in, and nurse is like, oh gosh, look what I just walked into, or God forbid, she doesn't even know it until there's a concentration. This is advance of them even parking the car. The entire hospital now knows this is a person who's been violent in the past. We will still deliver care to them, but we're going to treat this differently. And I think that's a really intelligent way to operate. Now, that is a task that people like Eric have to burden. But in the place that you've got the de-escalation team, you've got, in this case, a license plate reading camera at the egress points of campus. You now can have this more proactive approach of driving de-escalation before something gets out of hand. Because I do believe, in the case of a hospital, there are people who can be trained. It's a full-time job to manage these de-escalations. And I think it's just a sad but reality of the world we live in right now, where we do need these teams and we need these systems that can drive these proactive alerts.
Thank you. I'd actually like to use that now as the jumping off point to the de-escalation teams and have everybody weigh in, starting with Jennifer. Jennifer, we did have an audience question, and as we move into your discussing what kinds of de-escalation teams, who should be on them, we were asked, what are the units that have the highest incidence of violence? You mentioned your husband in the ICUs. Can you just put those off?
In general, what we hear, the emergency room is probably the number one area for the most violence, followed by ICU, and of course OB, particularly because of usually a lot of paternity, maternity issues and custody things going on in those departments. So, but the ED is one of those entry points into the hospital, and typically a lot of bad things happen, whether it's overdoses or gang violence, car accidents, domestic violence. That's all coming through the door constantly with everything else. So that's one of those areas that is high risk.
So Garrett mentioned getting the early warning that somebody is approaching the hospital that you have to be concerned about. So that means there's the sign-in desk. Mm-hmm. Then there's the initial triage treatment. So can you talk about the different kinds of personnel? Because does it always, who should be involved? And does it always have to be a social worker too, or a security guard? Or can it be a trained nurse who is very good and is interested in trying to deal with these situations? Can you offer your perspective? And then I'd like to ask everybody else to pitch in.
Absolutely. I think, as we've spoken about, it really looks at the resources of every healthcare organization, because a large academic center in a large metropolitan area versus a rural area is going to have different resources. So first and foremost, everyone in the organization should be educated on de-escalation techniques. So that should not be unique for a team or another group, but every individual in there should have de-escalation training, at least on a regular annual basis. And then looking at the needs of the community, I think oftentimes then some people want to make sure that nurses are the ones that are constantly the front person in de-escalation. We put a lot of things on nurses. And so often, we don't look at some of our colleagues, such as social work. Social workers are a key staff person in those teams to help decrease and help with de-escalation, especially if they're partnered with security guards, partner with maybe the police force that might be on the hospital campus, and with other clinicians, a physician, an advanced practice nurse. So when you look at the team component, it really does vary depending on the area, but looking at people, not just nurses, but looking at the whole host of other people available for that area and make the team appropriate.
Eric?
I would agree wholeheartedly. I think probably the biggest determiner of success in that is just aptitude. Do you have the right skill set for that? Are you there for the right reasons? Are you able to talk to people? So I think we can train anyone in de-escalation techniques, but they really have to want to do de-escalation techniques. Sometimes there are people who just don't have that skill set and can just further aggravate the situation. So I think just picking the right people. And if you don't have a lot of people on your team, it may be very sparse on what you have to work with. But if you don't have a lot to throw at the problem, I think the training becomes even more important at that point, because you're going to have to teach new behaviors in order to prevent the situation from continuing to escalate.
Jim?
Yeah, I wholeheartedly agree with Dr. Kennedy and Eric in that the resources that an individual healthcare worker has at their disposal makes all the difference in the world about safety, about support, and it sends such a message. It is an actionable item. It sends a message. And so I would agree with all of those comments. I also think that the issue of education is it's never a one and done. We are constantly learning. We are constantly evolving. As I mentioned, that village keeps expanding and broadening. That is true with our educational efforts as well for de-escalation training. De-escalation training may not always be the solution. It may not be sufficient, where we may have to heighten it to a behavioral emergency response team or a BERT team. And then that's a group of individuals with specific training that can support that bedside clinician. So it's about support, it's about resources. So I would agree with all those comments.
Jim, we also had a question from the audience about that sort of ties in directly in this, the difference between, do you see a different rate of incidence between rural and urban institutions? And also, there's a different relationship that a small community hospital has, say, with the rural community, maybe a couple thousand people, and a big urban institution. Can you talk about how that might impact the de-escalation? I mean, are your neighbors coming through the door if it's a rural institution? So first, are there higher rates in urban versus rural per capita? And is there a difference between how a de-escalation team is conceived if it's a small hospital versus a large one?
I think that's an excellent question, Liz. And I'm going to speak anecdotally to the first part of your question, and that is that what I hear from a member hospitals anecdotally is that in the larger urban areas, the reporting might be more than in the rural, but that, in my mind, does not equate to actual incidences. It may be that they occur, but they're just not as reported. And there might be a number of reasons for that being the case. To the second part of your question, you're right. I mean, smaller communities are connected, and many smaller communities have relatives who work at a local hospital. The local hospital, in many cases, is the largest employer in their community. It is the front door to the community. It is the resource of the community that is held sacred because it's their place of safety for care. And so the way that tolerance occurs in that smaller community may be different than in a larger urban setting. Again, my first comment about tailoring the plan to the environment, the community that you serve, I think that's extremely important to know who your community is, who are the individuals that you're serving. I think the other part of that is many times individuals seek care at a small and rural facility, but then may need to go to an urban facility for more extended services. And so, it's so important to have good handoff and good communication. In the clinical world, we call it verbal report, but it's handoff nonetheless. And sometimes we don't include the risk potential for violence in that handoff, but it is part of care. I would defer to Dr. Kennedy on this as well, but it is absolutely part of care that we in the clinical world hold very, very sacred.
Jennifer, I'll let you respond to Jim and then Garrett. Go ahead, Jennifer.
Absolutely. And I think, the most, one of the important parts I want to speak back to, because I lost my train of thought on that one, was the reporting mechanism and making sure the organizations have the data that they need and that everyone needs to be reporting. And making sure organizations, though, too, constantly, and again, not just the de-escalation training and the constant training, but also training on the system. We surveyed nurses, and what we found was a lot of individuals didn't even know the system was in place or the structure was in place for reporting and how to do it. So part of those annual trainings and the continuous trainings, whether, regardless of what setting you're in, is making sure that all the clinicians and the nurses are trained on the system and know how to report it, because that's a key portion of the education and training.
So, Garrett, feel free to add to any of the points that you heard. And then I'd like to talk to you about this need to build a relationship with law enforcement locally. So a lot of times, as we've heard, and as one of our audience members said, they don't seem interested, or perhaps they're overwhelmed, the local law enforcement, or, there's a problem getting consistent reporting. Do you have thoughts about how you can sort of get this dynamic where everybody feels it's to everybody's advantage to work together?
Yeah. I mean, look, as I mentioned earlier, we're proud to support about 5,000 law enforcement agencies that use our products every day to solve crime. And we service a lot of customers like hospital systems or retail providers where they get frustrated because one incident doesn't lead to an arrest. And that's common. That's common in shoplifting. That's common in organized retail crime. There's a lot of parallels there. But what we have seen is that while that is true, where we've seen success is when a hospital system is a part of building a big enough case that actually does register for a police department. And I think this is particularly a problem in our urban environments, right? We've got customers where they barely have time to chase known felons. The outstanding felony warrants, they barely have time to go after that. And so, yeah, it puts them in a particular tough situation when there is an act of violence that happens on campus and a nurse has been injured. And what do you do? What do you do? And so what we have found, though, is that when there is a collaboration and it's a viewed partnership of we have a mutual goal between our hospitals and our law enforcement agencies to create safer communities, right? And one's maybe from a more medical, physiological, emotional health, and one is from a physical safety, it's still the end goal. And so what we have seen is oftentimes the evidence captured, the cases developed inside of a healthcare system begin to build a much bigger case, which does lead to an arrest. Because the odds are, right, let's be realistic, if someone's violent in a hospital environment, they're probably violent in a lot of other places. And having that continuity of case can really lead to the appropriate level of justice delivered in those situations.
And you actually have concrete evidence. I mean, you can have, for example, say a crime happens. I'm sure you have examples from your experience of assaults in parking lots outside of hospitals.
Yeah.
And then
go ahead.
Go ahead.
No, you go ahead.
I was going to say, so you have surveillance tapes. You have, right, so you have evidence that can lead to a case being made.
That's right. And I think what we always try to talk about is I wish it was as easy as they show it on TV, where whether it's Law and Order or NCIS, just like crimes just get solved. And we forget that there's actually a criminal justice system involved, and the burden of proof has risen dramatically in our society, which I think is actually a pretty good thing. Eyewitness testimony used to be good enough. Nowadays, if there isn't hard video evidence, it's dismissed. And I think that's largely been proven to be better for our overall criminal justice system. But what it does mean is that if you think about something like a parking lot, you need to have video surveillance. And that is both to the safety of the vehicles, right? No one wants their car to get broken into. But more importantly, if you're ending your shift at 10 o'clock or ending your shift at 4 a.m. and it's dawn or dusk, I think as human, I want to know someone is looking out for me. And maybe there isn't an actual human watching the camera, but that there is going to be video evidence. And when you can then associate that with a license plate, associate that to get to an individual, whether that leads to an arrest the next day, or whether that is then the second or third incident that now leads to the warrant to go make an arrest, it is really about working together with law enforcement and having that concrete evidence, because it's one thing to arrest someone. It's a different thing to actually hold them accountable in the criminal justice system. And that burden of proof has gone up quite a bit in the last few years.
So, Eric, I know you have very strong feelings on this. You have an extensive career in law enforcement. So can you bring your perspective about how an effective relationship can be built between a hospital and its local law enforcement agencies?
Certainly. As you alluded to, I was in law enforcement for about 30-something years. So I see law enforcement as our partner in our efforts to ensure a safe environment. As Garrett alluded to, we've got potentially different goals, but those goals align around keeping people safe. So we want the safe, healing environment. We need their help in doing so. So I think developing meaningful relationships with your local law enforcement is important. Whenever we have an emergency call, I want them thinking, that's Eric down the street who has an issue and he's calling me for help. It's not the hospital's calling again and there's a problem. So we try to definitely make sure that we do that. We also want real-time communication with them around potential issues. We've talked a little bit about lack of prosecution. I can tell you that is a concern, I think, at every healthcare organization in the United States. We have had meetings with our local law enforcement, even our prosecutors' offices, and we said, hey, we're sending cases down and nothing's happening with those cases. And what we determined was that people who have behavioral health issues or people who commit crimes on healthcare property commit crimes elsewhere. And quite often cases will get bundled and they will say, we're going to give you 10 years for these 5 particular crimes. Take the plea, or you're going to go and we're going to, try to give you 25 years. So people will often take the plea deal. And so we're not made aware that, our case was part of that plea deal. All we know is that, case has been dismissed. So following up with your local prosecutor's offices and having those relationships with them as well, to where you can call and say, this particular nurse had an incident. She was assaulted. She was hurt. She never got called to testify. She doesn't know what's going on with the case. And they can tell you that, we didn't dismiss that case. What it was rolled into a bigger case and the person took a plea and now they're going to serve even more time because of it. So I think having those relationships is critically important.
Jim, and then Jennifer.
Yeah, I will just dovetail onto what Eric said. I can't agree anymore. I mean, the relationship building is so very important, but let's talk for a moment about how we can best build those relationships. We can do it in a number of ways. We do it certainly through communication, but communication can happen through training, joint training programs, through simulation programs together, where we are at the table together, if you will. We're working shoulder to shoulder, and we no longer have titles. Now we are in this together. We're partners. That's a different kind of relationship. So when Eric picks up the phone and calls, this is now my partner, who's someone who's going to support me. We are aligned. So that's a really strong relationship builder, in my opinion, and in the feedback I've received from our member hospitals. I think another one is proactive community plans. If this should happen, what will we do? How will we mobilize? How will we talk to each other? That is also very critical. Some people call them community care plans, but make no mistake, it's all very proactive. It's talking about a situation before it occurs, so there's a plan in place. So those are items I would offer.
Jennifer?
I think, having that feedback loop, what Eric spoke about, is critically important, because we're up to about 40 states who have increased penalties related to assault on nurses. But if people are reporting and never hearing anything, then the assumption is that nothing's ever done. And so having that feedback loop will be vitally important, because I think that in itself will increase people reporting if they truly know that something is going to be done and that their concerns are heard. But and as well as knowing that the organizations are doing what they can to help stop it, because it's great that we can, get people to press charges and get people put in jail, but people would rather not get hurt to begin with. So again, going back and focusing on those preventative measures so that we don't even have to deal with the rest of that downstream issue.
Garrett, before I move to our final piece, I'm listening to the communication side of it. And there seems to me there's a number of elements of communication when you're building a plan, but also when a violent return patient comes on campus again. And also when there's a mass shooter or something, how these alert systems, the communication systems, can you talk a little bit about a best practice for that element?
Yeah, I mean, I think Eric said something that I fully agree with, which is it's important that, as a healthcare provider, you have a very close relationship with the city government of which you sit inside of. And that's both the elected officials, which your mayor, your city council, city manager, and then law enforcement. Because thankfully it's none of our jobs to make the arrest, to deal with that first response. And there are sadly a handful of examples that we've seen where, because of that existing relationship in a mass shooter situation, a rapid collaborative response led to an arrest. And if you look at, somewhere like in my hometown in Atlanta a few years ago, where there was an active shooter in a hospital system that happens to have our product, they went from an active shooter to a license plate. Since it's the same system, Atlanta PD, Cobb County PD, every single surrounding agency in the city knew of what car to be looking for. It was automatic in their system. There was no need for mass communication because the right people were aware at all times. And it's the hard work of those security individuals as law enforcement individuals that led to the safe apprehension. And so to your point, Liz, those are hopefully situations that are very far and few between. But when they do happen, I think it's important that as a big part of a community, we've sat down and said, okay, what's the action plan? And what are we doing? What are you doing as local law enforcement? What are we doing for our employees in the hospital? And I think in the case of our Atlanta example, it was executed with near perfection. And this is a horrible situation to begin with, but for the people that are trained dealing with this, having that plan, having it communicated, they kept as many people safe as possible.
So we have maybe a minute left for each of you, and I'd like to direct the people where to get help, where to get tailored ideas for their institutions or memberships. Jim, I know, for example, OHA has some programs that makes available to all its members. Can I start with you, and then Eric, Jennifer, and Garrett?
Absolutely. What we do well at this organization is we convene our members, and we have 7 professional affiliated organizations within the umbrella of our association. Convening them is so valuable because they bring to the table effective strategies. They share education, they share solutions. No one has to reinvent the wheel. Sharing also outside of our state. For example, with the Massachusetts Hospital Association, who's done this work, Dr. Pat Noga in January published a white paper. On our website, ohiohospitals.org, you can find our white paper and our toolkit, which was developed from our member hospitals very freely and willingly. And so I would encourage you to visit that as well. And then collaborating with other professionals in this regard. For example, University of Michigan Medicine, their Senior Director of Security, Brian Uridge, very willingly shares his resources. I know many of you know Brian and his solution. And then we aligned with a corporate partner in our state, KLA Consulting. We vetted others, but this is an organization that has, emergency department individuals, HR individuals, pharmacy individuals. These are people who have worked the hospital footprint, who are doing consulting and training in this regard. So that alignment, I think, is so very important.
Thank you. Eric?
I would suggest if you are interested in healthcare security, you have a healthcare security department, to visit www.ia hss.org and encourage your security team to do that. I would also say reach out to me on LinkedIn. I know there's a lot of questions we didn't get to today. I'm happy to try to answer some of those questions and point you in the right direction. And then I would just like to really end by saying that workplace violence is not solely a healthcare issue. It's a community issue. We really need to really look at this and start working on it, or we're going to have just this huge issue of lack of access to quality healthcare. And we're going to have issues around the cost of healthcare, on patient outcomes. There are so many different things that are going to be tied to this. And I feel like we really need to start prioritizing the safety of our caregivers, because without those caregivers, I saw a report that said 175,000 caregivers left the industry last year. That means that's 175,000 caregivers who are not working in your community to provide you with the care you need. So really involving your local government, as James alluded to, state government, the U.S. government, companies like Flock Safety here. I think it's associations like ANA and IHSS all working together to try to escalate this to people and say this is going to have long-lasting effects on our access to quality healthcare if we don't do something to solve it.
Jennifer?
So I would, I agree to everything that's been said. You go to the American Nurses Association at nursingworld.org and type in workplace violence. You can get a bunch of resources there. This is a community issue, and if I think about the patient who has a heart attack and who needs to come into the emergency room, you're going to want those caregivers there, and you're going to want that safe environment, and the resources not pulled away because of an act of violence. So this is really a community issue, and we need to partner as healthcare providers, security, and the community to really resolve this for the well-being of the communities.
Thank you. Garrett, final thought?
I think actually I'm going to maybe close out the things that I heard that I need to push down to our team internally. It's just the importance of driving a collaborative, inclusive, to Jim's point, approach. Because I think Eric and I might come at it from the same point of view, having a bit more of a security first mentality, whereas Jennifer and Jim are looking at it from our true healthcare workers but how do we find this balance? And so I think in general, one of the best things is technology solves a lot of problems, Liz. You still need people. You still need great people. And I think as long as we continue to focus on attracting and retaining incredible healthcare professionals and remembering that technology exists to prop them up, to feel safe, to continue to come to work, then I think we're striking that right balance.
Thank you. I'd like to thank Garrett Langley, Eric Clay, Jennifer Mensick Kennedy, and Jim Giuliano for shining light on this absolutely critical issue, and also for their insights on how each institution can find the right mix of approaches to keep safe the healthcare workers whom we all rely on to keep us and our families safe and well. You can learn more about future virtual events at usnews.com events, but thank you again to our outstanding experts and to you, our audience, for attending.